It's my great pleasure to introduce our next speaker, Dr. Angie DeMichele from Abramson Cancer Center, University of Pennsylvania. Dr. DeMichele is the Marianne and Robert McDonald Professor in Breast Cancer Excellence at the University of Pennsylvania, where she also serves as the Director of Clinical Translational Research in Solid Oncology and co-leads the breast cancer program. Dr. DeMichele chairs the ECOG-Akron Breast Committee and also serves on guideline committees for ASCO, ESMO, and others. So we're very pleased to have you here, and Dr. DeMichele will update us on management of HER2-positive metastatic breast cancer.
Great, thank you so much. It's a pleasure to be here. I did have to restrain myself from wearing my Philadelphia Eagles jersey. I'm sorry, I know it's a sad time, but it was really our turn. So I do have my hat in my bag, but my mother said, I don't think you should wear it. It won't really make people like you very much. So anyway, moving on. It is really a pleasure to be here, and I enjoy working with Priyanka on the Breast Cancer Steering Committee, and it's great to be in your neck of the woods. So we're going to move now to HER2-positive metastatic breast cancer, and I'm just going to touch on really what I think are some of the most salient things that are happening in this field, in this particular type of breast cancer, based on some of the data that we saw at San Antonio this year. So I think one of the main questions is, can we build on our solid foundation that we have to further improve outcomes? And I'm going to show you really sort of the state of the art in those who are HER2-positive, ER-positive with the Patina trial data that came out this year, ER-negative HER2-positive breast cancer, and what is the role of immunotherapy, and then other agents that are coming down the pike. And then, with all of these agents, I think the question is, how do we select which drug to give and in which order? We know, the data from these large clinical trials and how populations of patients do. But you have that patient sitting in front of you. How do you select the drug that is best for them at that given time? Are there things about the tumor that we can use to help pick the best drug? And so we're going to talk a little bit about biomarkers in this space. And then finally, of course, we know that central nervous system disease is a major problem in HER2-positive disease. And so there was some very interesting data at San Antonio on a new agent, and I think it really provides great hope for our patients. And so I'm going to just start with my key takeaways, because I've learned that in education, this is the best way to make sure that you learn everything that I am about to tell you. So key takeaways from my talk today are that the addition of palbociclib provides meaningful prolongation of progression-free survival, about 15 months when added to endocrine therapy for HER2-positive, ER-positive metastatic breast cancer. And I think this begs the question of whether all HER2-positive, ER-positive patients should get both endocrine therapy and palbociclib, but at the very least, they should be getting endocrine therapy with their HER2-directed therapy during maintenance. And there are lots of things we don't know yet about other CDK4/6 inhibitors in this setting. There's currently no role for the addition of immune checkpoint inhibitors to HER2-directed therapy. There's some concern about additive toxicity that we'll review. We do need better biomarkers, and I think right now HER2 mRNA and maybe even BRCA status could be helpful. So far, circulating mutations, such as what we do when we get Guardant testing from the blood, are not predictive to ADCs. And then we do have more brain-penetrant drugs coming, and we're going to have to think about where we're going to put these drugs in terms of sequencing or adding them to ADCs. So this is our current treatment landscape in HER2-positive metastatic breast cancer for that patient who is also ER-positive. We typically now, of course, for the last, 15 years, have been giving the Cleopatra regimen, a taxane plus Herceptin and pertuzumab. And that has typically been given for 4 to 8 cycles as induction therapy, and then we drop the taxane and continue maintenance with just the HP and endocrine therapy. For those who are HER2-positive and ER-negative, we do the same but without the endocrine therapy. Currently, T-DXd is our second-line therapy, although that may change in the near future. Tucatinib triplets or TDM1 typically are our third-line therapy. And then, of course, we continued to treat patients who progressed through all of these with standard chemotherapy in addition to the antibodies and other agents that you see listed there. And so I think the real questions here in the first-line setting are whether we can improve how we are doing in these patients by adding additional targeted therapies based on whether they're ER positive or ER negative. This is the foundation upon which we currently build the Cleopatra trial. As you'll recall, this showed an improvement in both progression-free and overall survival and became the standard of care. But what's really important to remember here is that these patients could not have had more than one prior hormonal therapy if they were ER positive. They had to have at least 6 cycles of docetaxel, although fewer were allowed if they had unmanageable toxic effects. And this is really important when we talk about the patina trial in a moment, no concurrent hormonal therapy was allowed before disease progression. So even if the patients were HER2 positive, ER positive, they were not allowed to take endocrine therapy during their maintenance. And so remember these numbers, that 18.7 months of PFS is without endocrine therapy. So while hormonal therapy was not allowed on the trial, it has been added in general practice, but the impact of this on progression-free survival has really never been reported. Now, in that setting, when we go back to like even the development of CDK4/6 inhibitors, we know from the preclinical data that there is clearly activity in HER2 positive disease. HER2 positive activation leads to increases in CDK4/6 activity, and recurrent HER2 positive tumors express high levels of cyclin D1 and CDK4. And as you can see in the data down below there, that CDK4/6 inhibitors, when added over control, delayed tumor recurrences in these HER2-driven tumors. And we've had some successes using CDK4/6 inhibitors in the metastatic setting in HER2 positive disease. The Monarch-HER trial, which gave abemaciclib to patients in addition to trastuzumab with or without fulvestrant versus chemotherapy, showed that that triplet beat chemotherapy and trastuzumab with data that you see there of 8.3 months versus 5.7 months. And the Patricia trial from Spain also showed a benefit. So into that setting, and remember this is all the way back like 2015 when this trial was initially designed, came the Patina trial. And so the Patina trial was designed to look at whether the addition of a CDK4/6 inhibitor, palbociclib, to standard trastuzumab, pertuzumab, and endocrine therapy in the maintenance phase of treatment of metastatic, first-line metastatic ER-positive, HER2-positive breast cancer would prolong progression-free survival. So these patients had no prior treatment in the advanced setting beyond induction. So the patients were allowed to have gotten 6 to 8 cycles of a taxane, and then if they showed a good or stable response, they were allowed to then go on to the trial. So they did not enter the trial prior to the chemotherapy, they entered the trial after the chemotherapy and then were randomized 1-to-1 to either receive the palbociclib in addition to their other agents or not. There was no placebo. 518 patients were planned, and they were treated until progressive disease or toxicity. You can see the stratifications down below, which were pertuzumab use, prior anti-HER2 therapy in the neoadjuvant or adjuvant setting before they relapsed, response to their induction in the metastatic setting, and the type of endocrine therapy, which was limited to fulvestrant or aromatase inhibitors because there was no good safety data available at that time for palbociclib and tamoxifen. This is the statistical plan for the Patina trial. So the primary endpoint was investigator-assessed progression-free survival. There was 90% power to detect a minimal hazard ratio of 0.667, and the final analysis was planned after 269 events. There were 2 planned interim analyses. Now, the key secondary objective of overall survival was hierarchically tested at the interim and then would be tested at the final. And the final overall survival analysis requires 247 events. Now, again, I just want to call your attention. This is on the far side there. From the protocol, at that time, we believed that the medium control arm in this study was assumed to be 13 months of progression-free survival. Therefore, a risk reduction of 33%, or an improvement by 15% was anticipated with a median progression-free survival in the palbo arm of 19.5 months. So that's how the trial was designed. That's the difference that it was designed to see. So these are the patients who were enrolled, 261 in the palbo arm, 257 in the control arm. And in terms of balance, you see that all the key factors were well balanced. And importantly, in both arms, patient got 6 cycles of induction taxane before entering the trial. Also important to point out that 3/4 of the patients had gotten prior anti-HER2 therapy in the neoadjuvant or adjuvant setting, and that the bulk of these patients had a complete or partial response to their induction therapy based on their doctor's assessment. So these are the primary results for the primary endpoint of progression-free survival, and you can see that the addition of palbociclib prolonged the progression-free survival from 29.1 months to 44.3 months. That's a hazard ratio of 0.74 and is statistically significant. But again, I want to remind you, look at how that compares to the statistical plan of 13 months versus 19 months. So clearly, we did not understand the natural history of ER-positive, HER2-positive breast cancer and the importance of giving endocrine therapy to these patients. And I think this is why it took so long to get these results, and so much longer than we anticipated it would take to get these results, because patients do well even without the palbociclib, are doing so much better than we had anticipated. And then there was really no difference in outcome by any of the stratification factors, so it didn't matter what their best response to induction taxane was or how well they had responded, whether or not they had gotten HER2-directed therapy in the adjuvant or neoadjuvant setting. This is the overall response rate and the overall benefit rate. I think what's interesting here is that you don't see as big a difference in the response rates as you see in terms of the benefits. And this is one of those things that tells us that, if a patient responds, they are going to respond for a long time. But there isn't such a huge difference in the response rates overall. And then here is the overall survival endpoint at this interim analysis. So it is immature. We don't see a benefit yet, but we only have 119 of the 247 required events. And then just to point out that there were really no unexpected safety signals. You heard this morning about palbociclib and neutropenia. Other toxicities like stomatitis, fatigue, and diarrhea were as expected in the trial. So I think the takeaways from the PATINA trial is that patients who have HER2-positive, ER-positive metastatic breast cancer have a better progression-free survival when endocrine therapy is added to the Cleopatra regimen. Dual targeting is important in these patients, but the addition of palbociclib had an even bigger effect by adding about 15 months to progression-free survival when added to the endocrine therapy in the maintenance phase. There were no new safety signals. So I do believe that this represents a new care standard, and the question will be whether there will be a label indication or whether this will just simply enter into guidelines in order to enable our patients to get access to this. And I guess this now starts to bring up some other questions about what we should do in the second line if patients progress on this. Do we think about treating these patients both as HER2 positive and ER positive in the metastatic setting? I say I've really kind of changed my thinking about this. I don't think about the fact that there's some HER2 positive patients who happen to be ER positive. I think that there are some ER positive patients who happen to be HER2 positive. And in fact, really, maybe what we ought to be doing is treating these patients more like we treat metastatic ER positive breast cancer, but just adding on the antibodies. And then where will we put this in terms of the ADCs that are coming up, particularly if the first-line setting changes? And then, of course, I think the important question here is, did we even need the taxane? Do these patients really require chemotherapy at all? You know, it's not easy. They lose their hair, they're tired, there can be low blood counts, there can be neuropathy, so it'd be lovely if we could stop giving chemotherapy to these patients altogether in this induction setting. Unfortunately, the CDK4/6 inhibitors, all of them, the patents are going to run out in the next 5 years. And so we can't really do trials to answer these questions because there isn't the opportunity to have the follow-up during the patent life of these trials. So we're going to have to figure out how to answer these questions, I think, in real-world settings, not in clinical trial settings, based on the way our clinical trials now are funded and carried out. Moving on now to immune checkpoint inhibitors in those patients who are HER2 positive and ER negative. There really has been this really great rationale for why you might want to think about adding immunotherapy in these patients. They often have high TILs, they can have high tumor mutational burden, they can have PD-L1 expression, and we know that HER2-directed antibodies do mediate ADCC, and so this really suggests that these immune checkpoint inhibitors could reactivate suppressed T cells and promote their activation in lymph nodes. But there has been mixed experience with this. We did see about a 15% response rate in the Panacea trial when pembrolizumab was added to single-agent Herceptin. The KATE-2 trial, which was a metastatic phase 2 trial, with TDM1, with atezo or placebo, was stopped early for futility. And notably in that trial, there was a higher than expected adverse event rate with one treatment-related death from hemophagocytic syndrome. The IMpassion50 trial was a neoadjuvant trial, and there were 5 grade 5 treatment-related adverse events in that trial, and it was also stopped early. So then we saw last year the Aviator trial, or TBCRC 045, looking at the use of avelumab in patients receiving navalbine Herceptin, which also was stopped early, the arm that had the 4-1BB agonist, on the avelumab arm had significantly longer progression-free survival. So into this, we saw, into this space, the NRG-BR004 trial was presented at San Antonio this year, and this was a trial that looked at the use of atezolizumab in first-line therapy. This trial in April of 2022 was stopped due to an imbalance in deaths in the treatment arm. Accrual was permanently discontinued at that time, and patients were unblinded. And at San Antonio this year, we saw the results. And what was really striking here, even though there were only 91 patients on the placebo arm and 95 patients on the atezo arm, there was about a 6% grade 5 toxicity rate on the atezo arm, echoing what we had seen in some of those other trials that I just told you about. Several of the severe adverse events were due to the treatment, and you can see there that there were 6 deaths on the atezo arm. Despite this very small number of patients who had been enrolled, there was a numerically improved progression-free survival in the atezolizumab arm, just with this small group of patients, no benefit in overall survival. So looking at this, I think that we're really still not at a point where we understand how to use immunotherapy for patients with HER2-positive metastatic breast cancer. There are these excessive deaths that we've seen in several trials now, suggesting that there could be some sort of synergistic interaction that's accentuating the harmful immune response. And is it atezo, or could it be all immune checkpoint inhibitors? We really don't know, so we need more work in this space. Finally, I wanted to just talk about the data on this drug pyrotinib, which you may or may not have heard of up to this point, because most of the development has been done in China, but this was presented at San Antonio as well. This is the PHYLLIS study, and here pyrotinib is given in combination with trastuzumab and docetaxel, so essentially swapping out the pertuzumab for pyrotinib in the Cleopatra trial design with progression-free survival as the primary endpoint. And what was seen here was a improvement in progression-free survival with the pyrotinib over placebo. And so that was 10.3 months versus 22.1 months, statistically significant. And in fact, there was an overall survival benefit. The drug does have significant toxicities, but these are as expected in this setting. And so the reason to know about this is because there has been a fair amount of data that has been shared about this drug, and it's approved in China in combination with capecitabine based on the Phoebe trial. But the problem is that the data that I showed you really doesn't include the right control arm, right? Because we use pertuzumab in this setting based on the Cleopatra data. And so it's not clear that this would ever get approved in the United States. It would really have to be better than tucatinib or neratinib and compete with the other ADCs. And so just keep your eye out if you hear about this drug. I'm not sure it's going to have a future here. I do think that zanidatamab, which is a bispecific HER2 antibody, which is in clinical trials now, looks more promising and is likely to be the drug that would next come into this space. Now I'm just going to finish up talking about biomarkers and brain mets. And I wanted to just show you a little bit about biomarkers that's been shown. And the reason this is important is this is DESTINY-Breast09. This is the trial that's looking at T-DXd in the first line against the Cleopatra regimen. This is likely to report out sometime in the next year. And this very well may change our standard of care based on everything we've seen about T-DXd in other lines of therapy. So it will be important for us to understand who are the patients who will respond better to an ADC upfront compared to a patient who could simply take a taxane with antibodies. Because there are differences in toxicity and cost, and so we want to be choosing these regimens based on what our patients will most likely be able to tolerate and what they will have the best response to. And I think that when we look at what the potential biomarkers are, we know that for antibody-based therapy, there are numerous things that could help us to determine which patients should receive these and how likely it is that a patient will respond. Everything from intrinsic subtype and mRNA levels to DNA mutations and the immune environment have been shown to be prognostic. There are also important factors that impact the response to ADC therapy. So if you think about ADCs, you've got the antibody, the linker, and then the payload, and so there can be differences from tumor to tumor and patient to patient in terms of their target antigen on the surface of the tumor cell, as well as their sensitivity to that chemotherapy payload. So at San Antonio, we saw a couple of very important studies that help us to be able to start thinking about how to select these therapies. This is looking at the HER2-DX assay mRNA score in patients who are receiving the Cleopatra regimen. And as I've shown you, this regimen established our standard of care. And in the original trial, it was seen that the level of IHC HER2 expression was related to the progression-free survival in these patients. The HER2-DX test is a test that looks at gene expression, and it has 3 different components to it. It is based on 27 genes and 4 gene signatures. So it includes an immune signature, so factors in the immune responsiveness of the tumor, proliferation, luminal differentiation, and then HER2 expression by mRNA. And what's important here is that, I meant to show you that, I cannot go backwards, that's okay. It's the mRNA score that was looked at here because the other parameters of this test are used in the neoadjuvant setting. But there had been real-world data showing that the mRNA HER2 score for the HER2-DX test was predictive, this is in real-world data, following first-line THP, following second-line TDM1. This could be used to try to understand who was most likely to respond. And so what was shown at San Antonio this year was data using the Cleopatra trial to test this assay, and what was shown is that there was a lower response rate in patients who had a low mRNA expression compared to high mRNA expression, worse progression-free survival, and worse overall survival. We also saw biomarker work on the Destiny Breast 03 to try to help us differentiate whether we could find markers for responsiveness to TDXD or TDM1. And here they looked at a whole variety of different markers that are obtained through the Guardant blood test of ctDNA. They looked at medium plasma HER2, adjusted copy number, and then they looked at mutations in the PIK3CA pathway, P53 alterations. They looked at HRD status and BRCA status. And what they saw was that although there was better prognosis with higher HER2 copy number in both the TDXD and TDM1 arms, there was no differential effect of this in the benefits of TDXD over TDM1. So this is a prognostic marker, higher mRNA, but not predictive of which drug to give. None of the other gene expression mutations showed any differential effect or reduction in the TDXD benefit. But what was interesting here is that both for the HRD and the BRCA status, that there was shorter progression-free survival with TDXD in those who are HRD positive or BRCA mutants. So this is something I think it's important to watch because this is consistent with other data that we have seen, suggesting that patients with BRCA mutations might be less responsive to TDXD, although they do seem to maintain their responsiveness to sacituzumab. So this may be an important predictor of whether patients respond to ADCs. And then finally, they also saw the emergence of TOP1, so mutations in the topo gene as a potential resistance mechanism for TDXD. So this also could be important in thinking about what we'll do for patients who progress on TDXD. So take-home messages here, plethora of new agents now in the metastatic HER2-positive setting. We need better biomarkers to help us select the best agents for our patients. In the first line, it looks like low HER2 mRNA expression might be helpful in identifying patients who don't have a great response to the Cleopatra regimen. And for TDXD, we really only have maybe potentially BRCA or HRD as a predictive marker. Moving on now finally to CNS disease. This still remains a very important problem with 30 to 50% of our patients developing CNS metastases over the course of their illness. We know that HER2-positive cells have a tropism for the central nervous system and that there's a very complex set of things that happen at that blood-brain barrier that allow that disruption and allow those cells to enter and enable brain mets as well as leptomeningeal disease. And so we need better treatments here. This drug, ZN-1041 from Roche, is a highly selective HER2 tyrosine kinase inhibitor that has been designed to penetrate the blood-brain barrier. We saw data presented at San Antonio after their phase 1 dose finding that identified the active dose. It was now combined with capecitabine and Herceptin, similar to the HER2 CLIMB regimen. And this was the result. And so this was really impressive, 73% overall response rate and a median progression-free survival of 14 months. So you see in this waterfall plot, virtually all of the patients responding to this and with reduction in CNS tumor size. Now comparing this, and this is not designed to be an official comparison, of course, because these two regimens have not been tested head-to-head, but it does suggest, if you look at that overall response rate, as well as the intracranial response rate of 64.9% for the ZN-1041 compared to tucatinib in this regimen of only 47%, and almost a doubling in the median progression-free survival, that this agent looks quite promising. It is more toxic, and so we will, I'm sure, be seeing more about this agent, how to manage its toxicities, and where it should fit into our armamentarium. And so again, just to complete and summarize my key takeaways, As seen in the PATINA trial, the addition of palbociclib provides a meaningful prolongation of progression-free survival, 15 months when added to endocrine therapy. All patients now should receive endocrine therapy in this maintenance phase, and I believe also palbociclib, and we'll have to see if we're going to be able to get this reimbursed. We have new questions that this has opened up for us about the best way to treat these patients moving forward when they progress on this regimen. We don't have any rule at the moment for immune checkpoint inhibitors and HER2-directed therapy, but I think there's still more work to do to figure out how to harness the benefits of those agents. Biomarkers right now are focused on mRNA expression and some intriguing data that needs to be really confirmed about BRCA and HRD in potentially helping us select ADCs. And then better brain penetrant drugs are coming, and we'll have to figure out how to integrate those into our armamentarium. And with that, I will thank you.